ventilation in ARDS. And over to Dr. Kamalpreet Sodhi.
Good morning, friends. So I'll be talking about ventilation in ARDS. I think you have already covered the ARDS as a component, and now we'll be talking about how to ventilate a patient in ARDS. There are few things we need to remember while ventilating a patient with ARDS. A heterogeneous involvement of the lung. When we look at the CT scan in ARDS, it must have been already discussed. This preservation of normal lung regions, there can be pulmonary edema or there can be dependent collapse and associated pleural effusions in the lung. So all these leading on to a small baby lung, what is known as the baby lung concept. Then we ought to remember that there can be VQ mismatch and the shunting, the leaky endothelium and epithelium, and the pressure differentials, which all are going to affect the ventilation. ARDS treatment comprises of the standard supportive therapy, the mechanical ventilation per se, the pharmacological therapies which may or may not work, and the rescue therapy. The ultimate goal is just to wait for the acute inflammatory response to resolve, the lung functions to improve, and preventing any further lung injury. If we talk about the basic management, it is just targeted to the underlying disease, antimicrobials for the infections, drainage of collections, rapid resuscitation if patient is in shock, aiming for the lowest intravascular volume or targeting vasopressors and inotrope so as to restore the organ perfusion. And once shock is resolved, what is important is the conservative fluid strategy with goal to keep patient's fluid balance net zero, which might even involve the usage of diuretics. So this is the target. Ventilation in ARDS. The aim is to increase the PaO2 and minimizing the risk of further lung injury. That is the most important thing we need to remember while ventilating a patient in ARDS. Hypoxia management, starting in early stages with increasing the inspired oxygen concentration. As the patient is well oxygenated at FiO2s of less than equal to 0.6, apparently stable, no CO2 retention, then what is just required is the close monitoring, continuous oximetry, and regular blood gases. NIV or their HFNCs, they're just an option for mild ARDS, and associated failure rate is very high. And invasive mechanical ventilation, it's needed when there's inadequate oxygenation, PaO2s of less than 60 millimeters mercury with FiO2 of more than 0.6. Rising or elevated PaCO2s more than 50 millimeter mercury, or there are clinical signs of incipient respiratory failure. If we talk about NIV in ARDS, no trials have actually directly compared non-invasive with invasive mechanical ventilation. Ferrer on comparison of NIV with supplemental oxygen found decreased need for intubation with NIV in all study populations, but except for ARDS. And no differences in outcomes were seen. So NIV as of now is only to be considered in mild ARDS with PF ratios of more than 200 associated no organ dysfunction. And in immunocompromised patients, especially for patients who are hemodynamically stable, are able to tolerate the voice mask and protect the airways. The basic rules for ventilation in ARDS, this we ought to remember at all moments when we are ventilating a patient with ARDS. What we use is the lung protective ventilation. We'll be talking about all these in details over the next 15 to 20 minutes. The lung protective ventilation, tidal volume target is 6 mils per kg. That is the plateau pressures should be less than 30 centimeter water. When we talk nowadays is the driving pressure less than 13 centimeters water, and associated permissive hypercapnia is permitted. So these rules should be remembered by heart. So lung protective ventilation is just keeping in mind the baby lung concept, and this is the standard of care in ARDS management. It basically involves using protective measures so as to avoid over distension of the normal alveoli. What is left behind in injured lung, the remaining normal alveoli, we have to protect them. How are we going to protect them? Using a more physiological, that's a lower tidal volume, avoiding high inspiratory plateau pressures, and appropriate levels of PEEP might be used so as to optimize the ventilation. The target is decreasing the pulmonary complications and improving the outcomes. So if we're talking about the lung protective ventilation, we talked about the tidal volume, the PEEP and the P-plat. So what's more important? Actually, all these may be lung protective and interactively they influence each other a lot. So the first thing is reducing the tidal volume. From where this concept came was way back in 2000 when the ARDS network published the ARMA trial, and they saw that ventilating a patient with lower tidal volume strategies, that's for 6 mils per kg body weight, that's targeting plateau pressure of less than 30, when compared with the traditional tidal volume, that's a higher tidal volume of around 12 mils per kg predicted body weight. So they saw that there was a 22% reduction in hospital mortality. And what was important was this mortality was there despite worsened oxygenation, increased PCO2 levels, and lower pH. And not only the mortality would decrease, also they were seen increase in the number of ventilator-free days and decreased organ failure. So the concept of low tidal volume ventilation came into being. So they say that if we can, if 6 mils per kg body weight, that increases the survival over 12 cc per kg. So do you think that going to as low as 0 cc per kg would result in immortality? Actually, no. Many studies have clearly shown that the maximum survival benefit is seen in the range of 6 mils per kg body weight tidal volume ventilation. The next concept is the plateau pressure or the driving pressure in ARDS. And the targets are P-plats of less than 30 and driving pressure of less than 15 centimeters water. So plateau pressure is the pressure applied by the mechanical ventilator to the small airways and alveoli. And how we calculate the plateau pressure is it's measured at the end inspiration when we achieve the peak inspiratory pressures, and then we have an inspiratory hold of around 0.5 to 1 second. And then the pressure plateaus down to a pressure lower than the peak inspiratory pressure, and that's the plateau pressure. This here there is actually the flow has actually stopped, and so this plateau pressure is important. And many meta-analysis have showed that significant correlation of P-plats more than 35 are associated with risk of barotrauma. And the ARDS network trial clearly showed that lower tidal volume ventilation with P-plat of 30 centimeter water, as we have seen in the previous study, was associated with low mortality. So the target plateau pressures are less than 30 centimeter water. Please do remember these values. So now, what's more important, tidal volume or the plateau pressure? Actually, both are linked, tightly linked together. As we decrease the tidal volumes, there's a decrease in the plateau pressures, and with increase in the tidal volume, the plateau pressure spontaneously increases. So herein the concept of driving pressure comes into being. So what's the driving pressure? We talked about the peak inspiratory pressure and the plateau pressures. And this difference between the P-plat and the PEEP or the baseline pressure, that is the driving pressure. So this is a P-plat minus P-PEEP. And this is actually a ratio of the tidal volume and the compliance of the lung. So the target driving pressures, what is recommended these days is a 13 to 15 centimeters of water. Then the optimal PEEP. Nowadays, we don't say high PEEP. We say the optimal PEEP. Please remember this. So what's PEEP? PEEP is the maintenance of positive pressures at the airways opening at the end of expiration. That's a positive end expiratory pressure. So what the PEEP does, it opens the alveoli, allows maximum alveolar recruitment and thereby improving the oxygenation, decreases injury by repeated opening and closing of small airways with applying the PEEP, prevention of airway and alveolar collapse, increasing the FRC, there's decreased VQ mismatch and shunt fraction is decreased, and the surfactant loss is prevented by avoiding the repeated opening and closing of small airways. So thereby the alveolar collapse is prevented. So PEEP we can apply as an incremental PEEP or a decremental PEEP. How we do it? In incremental PEEP, start with relatively low levels of PEEP and keep on increasing the PEEP by 2 centimeters of water until acceptable P plat of 30 centimeter water is there. So this is what the ARDS net protocol says. We'll be discussing this protocol in detail later on. The decremental PEEP strategy, we begin with a higher PEEP, say 20 centimeter water, and start decreasing the PEEP until most optimal oxygen pressures or the peak airway and compliance is achieved. Both strategies have to be done with close monitoring of the lung mechanics, including the compliance and the plateau pressures. The gas exchange has to be monitored. We have to set a target SpO2, PaO2, PaCO2 levels, and hemodynamics have to be monitored because PEEP is one thing which affects the hemodynamics a lot. So low PEEP versus high PEEP, no consensus because none of the studies have shown consistent effects. So we do not say that we use a higher PEEP or a lower PEEP. And because the effects of PEEP are actually variable, there can be over distension at one point, or there can be appropriate recruitment of the lung at other point. So what we define as the optimal PEEP. Optimal PEEP means the individualized PEEP achieved by keeping a balance between the lung recruitment, most appropriate lung recruitment has occurred, and we are limiting the over distension of the lung, maintaining the appropriate arterial oxygenation. So how we target the optimal PEEP? We have to go in for, we have to target the PaO2s around 55 to 60 millimeters mercury, plateau pressures of less than 30 centimeter water, and the driving pressure of less than 15 centimeters water. The next thing that we have to decide when ventilating a patient in ARDS is the mode of ventilation. Volume control, we know there's a constant flow rate, guaranteed tidal volume delivery is there with variable pressures, and it's not affected by the lung impedance, and more clinician friendly it is. But the pressure control ventilation, there's a decelerating flow. The pressure and time are variable, but the pressure and time are constant, but the volume is variable. So we have to look like what tidal volume is being delivered, and we can always limit the peak pressures. So which mode? Actually, none of the studies have shown any conclusive thing, and the studies are all underpowered. The systematic reviews also say that the outcome is unlikely influenced by simply using one breath type versus the other for all patients. So I always recommend that ventilate with whatsoever ventilation strategy you are comfortable with. Whatsoever you are using routinely, please use that mode only for ventilating a patient in ARDS. Yes, the consequences of lung protective ventilation, permissive hypercapnia. We don't say that this is a consequence. This is actually because of the controlled hypoventilation we are doing with low tidal volumes. We can have PaCO2 levels up to 55 to 60 millimeters mercury. We have talked about the ARMA trial wherein it was shown that the mortality decreased despite the high PaCO2 levels and low pH. So pH target with permissive hypercapnia is up to 7.25 and PaCO2 up to 55 to 60 millimeters mercury. Also, low lung protective ventilation is associated with worsened oxygenation, increased need for sedation or analgesia. There can be hypotension, arrhythmias, pneumothorax, and most important, the iatrogenic lung injury, that is the ventilator-associated lung injury. It can be because of high inflation pressures leading to barotrauma, over-distension leading on to volutrauma, or repetitive opening and closing of alveoli leading to atelectatic trauma, or the SIRS and the cytokines release leading to pyotrauma. So please do remember all these terms while ventilating a patient of ARDS: barotrauma, volutrauma, atelectatic trauma, or biotrauma. Also, since we are ventilating at high FiO2, so oxygen toxicity is another theoretical possibility of lung ventilation in ARDS. The ARDS net protocol. This is the crux of ventilation in ARDS. Whatsoever theoretical we have talked, how we are going to ventilate is as per this slide. This is a massive protocol derived from multiple trials, wherein lung protective ventilation, aim of ventilation is a PaO2 target of 55 to 80 millimeters mercury, tidal volume of only 6 mils per kg, P plat to be kept under 30 centimeter water, and pH to be kept over 7.30 using any ventilator mode. So this is the gospel of ARDS net protocol. So how we are going to ventilate? Let us talk the ventilator setup. First of all, we need to calculate the predicted body weight because the tidal volume we are going to set is as per the predicted body weight. So this formula is easily available on the Google. You can Google it down and then select any ventilator mode. Set the ventilator settings to achieve a tidal volume of 8 mils per kg. Start with 8 mils per kg and then start decreasing the tidal volume by 1 mil per kg at around 2 hours interval until we have a target tidal volume of 6 mils per kg predicted body weight. So set initial rate to approximate baseline minute ventilation, and the rate should not be more than 35 breaths per minute. And we are going to adjust the tidal volume and the respiratory rate to achieve the pH and plateau pressure goals, which we are going to discuss in the next slide. So the plateau pressure goal we have talked about, it's less than equal to 30 centimeter water. So we need to check the P-plat. How we're going to check it, we have discussed by applying a 0.5 to 1 second inspiratory pause, and at least 4th hourly this should be checked, or whenever we are changing any of these, the PEEP or the tidal volume. Whenever we change, we have to check the P-plat. If the plateau pressure is more than 30 centimeters water, what we are going to do, we are going to decrease the tidal volume by 1 mil per kg until minimum of 4 ml per kg. And if P-plat is less than 25 and we are ventilating with a tidal volume of less than 6 mils per kg. So what we do, the P-plat is still below the target. So we can increase the tidal volume by 1 mils per kg until we reach P-plat of more than 25 or tidal volume of 6 mils per kg. If P-plat is less than 30, but breath stacking and disc synchrony is occurring, we are seeing that the patient ventilator asynchrony is there. So we may increase tidal volume by 1 mil per kg increment up to 7 or 8 mils per kg, targeting the P-plat remains less than equal to 30 centimeter water. So this is how we target the plateau pressure. The pH goal we have talked about, it should be more than 7.30, but we do not want an alkalotic pH also. So we target a 7.30 to 7.45. So if pH is less than 7.30 up to 7.15, what we start doing is increasing the respiratory rate until pH is more than 7.30, PCO2 is less than 25. And the maximum respiratory rate that can be set is 35. If pH is less than 7.15, herein we can use bicarbonate, increase the respiratory rate to 35. And if pH still remains less than 7.15, what we're going to do, we may start increasing the tidal volume by 1 mils per kg up till a target pH of more than 7.15 is achieved. But for herein, we may have to exceed the plateau pressures also more than 30. So please do not go beyond 35. And if there is alkalotic pH of more than 7.45, decrease the ventilator rate. And IE should always be, the duration of inspiration should be less than the duration of expiration. So this is how we are going to ventilate the patient. And then the other thing we have to look for is the oxygenation goal. PA2 target is 55 to 80 millimeters mercury. And how we are going to monitor the patient on the bedside is SpO2 of 88 to 94%. To use the ARDS net protocol says the incremental PEEP. Like we keep on increasing the FiO2 and side by side we keep on increasing the PEEP also. So we can use this table while we are ventilating the patient of ARDS. So we keep on increasing the FiO2 from 0.3, 0.4, 0.5 up to 1, from PEEP of 5 to 8 to 10, 12. It says 18 to 24. Actually, if you ask me personally, I have not used beyond 20 centimeters water. So this is what I can say. But yes, you can, as per the ARDS net protocol, you can go up to 24 centimeter water of PEEP with FiO2 of 1. And it also uses sometimes higher PEEP and lower FiO2s. At lower FiO2s only, it starts increasing the PEEP. So anyways, we go, this table is the maximally used table clinically. So now we have talked about the ventilation, how we're going to start any mode, starting with high FiO2 and optimal PEEP we have to achieve by looking at the SpO2 or the PaO2 targets. So we can get the ABG very frequently, initially maybe 2 hours or 4th hourly, and later on as we the patient settles down, the ventilation is more stable, so we can have more ABGs at lesser, at more frequencies, more times. So weaning is another aspect which we always forget, because once we start with ventilation, we have to wean the patient. So if the anticipated ventilation requirement of more than 10 days, consider tracheostomy. As the underlying disease resolves and patient improves, we have to go in for spontaneous breathing trials. And for this trial, the patient should be hemodynamically stable, able to meet the oxygen requirements through non-invasive methods. And SBTs are usually conducted over 1 to 2 hours, as is the routine for any other patient. And extubation is more likely successful if the patient remains hemodynamically stable with good ventilatory parameters. The spontaneous breathing trials, the eligibility and the parameters remain the same. We have to have a hemodynamically stable patient with settled minimum ventilation, and PEEP should be less than 5 centimeters water. Rescue therapies. These are another thing which is important for patients with ARDS. So rescue therapy involves the recruitment maneuvers, and the current recommendation for usage of recruitment maneuvers is only after, if at all there is any brief disconnection of patient from ventilator or there is refractory hypoxemia. What the recruitment maneuvers do, they open the collapsed alveoli, move the fluid to periphery, and overcome the shear stress. We have to, how we are going to do it, we'll talk in the next slide. But since they require high sustained pressure, so there's a chance of barotrauma and the hemodynamic instability. So they have to be done while we are doing the recruitment maneuvers. We have to monitor the hemodynamics stringently. There are many methods of doing the recruitment maneuvers, but most commonly used is the applying a continuous positive pressure of around 40 centimeter water for 40 seconds. This is the most frequently used recruitment maneuver. You might be asked like how you can give the recruitment maneuver. You can give the intermittent size. There's an intermittent increase of PEEP or progressive increase of PEEP. They all will cause the opening of the alveoli. Prone positioning is another recruitment maneuver. I'll not say this is a rescue therapy. I say this is the norm in ARDS, because nowadays the recommendation is early proning, as early as we can. So what the proning does, the recruitment of dorsal atelectatic lung units, increasing the FRC, blood flow redistribution occurs, and this decreased VQ mismatch. And because of the abdominal pressure release, improved respiratory mechanics, changes in the diaphragmatic motion, and the cardiac output increases. Also, the secretions removal is improved. This was first shown by ProSiva trial, wherein proning of at least 16 hours in patients with severe ARDS, it was shown that the mortality at both 28 and 90 days and the ventilator-free days, they massively improved. And now it is said that proning is the safest recruitment maneuver, and start proning as early as possible. ECMO is another strategy which is now recommended for ARDS patients, and the recommendation is for any severe ARDS patient, especially if the PF ratio is less than 80 millimeters mercury, or when mechanical ventilation becomes dangerous because PEEP plats are increased despite optimal management of PEEP, usage of neuromuscular blocking agents, or prone positioning, we have to decide for ECMO. CESAR trial, again, we should know this name. It was a trial done in 180 patients, wherein it showed that with use of ECMO, the survival was massively increased by 63% in ECMO arm vis-a-vis. With conventional ventilation, the survival was 47%. So the recommendation said that we have to transfer adult patients with severe but potentially reversible respiratory failure to a center with ECMO-based management protocols as soon as we can. Alternative ventilation strategies, again, they are sometimes asked in the exam. ACCORD can be used, APRV, inverse ratio ventilation, the high frequency ventilation, or the inhaled nitric oxide. But the mortality benefit with any of these strategies is still to be shown. Briefly about APRV, it's an inverse ratio pressure controlled intermittent mandatory ventilation wherein unrestricted spontaneous breathing is allowed. It's basically based on the principle of open lung approach, and alveolar recruitment is occurring with APRV, leading on improved oxygenation, and we are preserving the spontaneous breathing. There's improved hemodynamics and potential lung protective effects have been seen. But there are risks of volutrauma, work of breathing is increased, and energy expenditure because of spontaneous breathing is there. So what is done in APRV? We target two levels of airway pressure: high airway pressure of around 28 to 30 centimeter water and low airway pressure. So at high airway pressure, spontaneous breathing is allowed, and here the T is high. We give high airway pressures for around 4 to 6 seconds, T high, and low airway pressures wherein release of the patient, the lung is in resting state, and this is allowed for around 1.5 seconds or so. So there is a variation between two levels of pressure, and spontaneous breathing is allowed. Inverse ratio ventilation, there's a prolonged inspiratory time as compared to expiration, thereby sustained inflation, preventing the collapse of alveoli. And this basically increases the mean airway pressure and improves the oxygenation. But potential cause of increased I is obligatory decrease in the expiratory time, thereby air trapping and auto PEEP occurs. There can be barotrauma, hemodynamic instability is very high in IRV, and increased need for sedation and the neuromuscular blockers. High frequency oxygen ventilation. This, herein we are ventilating at high frequencies of around 300 to 900 ml per minute with tiny volumes. That's around 1 to 3 mils per kg. The small tidal volumes, they limit the risk of volutrauma, and the rapid pressure oscillations create a mean airway pressure that prevents small airway collapse and limits the risk of atelectic trauma. But this requires a specialized ventilator, and it is being constantly used in neonates, but not very useful for adult ARDS. Supportive therapy, yes. Neuromuscular blockers, clearly yes, for cisatracurium and other neuromuscular blockers up to 48 hours, they have shown that yes, they are beneficial. Steroids might hasten the resolution of late fibroproliferative ARDS, but no mortality benefit. Increased ventilator-free and shock-free days have been seen. But beyond 14 days after onset of ARDS, it has clearly shown worsened mortality. Fast hug BID, as we do for any other critically ill patient. Nutrition, start early, especially the enteral nutrition is the preferred one. And thromboprophylaxis for all patients if there is no contraindication. So to summarize, identify ARDS early, NIV option only for mild ARDS. We have to ventilate with low tidal volume, 6 mils per kg, not 8 mils. Aim is to have plateau pressure minimum, not just less than 30 centimeter water, that's a target, but minimum plateau pressures with some degree of permissive hypercapnia, PaCO2 of 55 to 60 millimeters mercury, and pH of 7.25, that's acceptable. PEEP titration based on FiO2 and optimal PEEP we should achieve. Early proning and recruitment maneuvers are good only after any circuit disconnection, associated problems of hemodynamic instability and barotrauma must be kept in mind. And rescue therapies, APRV, it is being, now the studies have actually shown the benefits, but yes, it is being recently recommended for ARDS ventilation, and ECMO certainly yes. So we do plan to shift the patient to ECMO unit as early as possible. To conclude, the magic bullet ventilatory strategy not yet available. Mr. Good Mode is actually still awaiting, and ARDS NET trial is still the benchmark. Even after 22 years of its inception, we still ventilate our patients of ARDS as per the ARDS NET protocol. And happy lungs or the pretty lungs, the debate continues, but the prescription is buy time, do least harm. Thank you.
Thank you, Dr. Kamal Soti, for this talk on ARDS. It was a very extensive talk, and I hope third year PGs must be able to pick up the most points. And then, they need to study certain things in greater detail, certain things out of this topic, maybe asked as a single question, a note on, APRV and note on other she has explained you how to recruit the lung recruitment. So this has got many independent topics in it, then explaining the APRV mode. So, this is giving you the gist of so many things which, are there in difficult to ventilate patient. So similarly, like she has said, it is a difficult to wean patient also. And great expertise is required to ventilate these patients. But, these are the basic principles which you must understand: volutrauma, then your barotrauma, atelectrauma, biotrauma. And, then at the end of it, I must add from my side that, we have certain, the causes of ARDS, causes leading to ARDS. And if that cause is remediable, we must look at that also. Primarily, we should look at what is causing this. Sometimes infections like in COVID, we had ARDS pictures there, we can't do much, whatever antiviral and other things we were able to give, And then similarly, we have a list of things leading to ARDS, and that also should be borne in mind. With this, any questions in chat box? I don't think we have any questions in this in the chat box. Thank you, Dr. Kamal. Thank you so much. It's been your repeated participation in this program. Hope to have further, participation also in this program if at all we design. Thank you so much.
Thank you so much. And thank you for making me a part of it. I really enjoyed. And going back to the basics, that's the most important, because what to remember at the bedside is what I had just pointed out. And as you rightly pointed out, there might be questions beyond these, but like I thought the APRV had already been discussed in the morning session on advanced modes. So I did not spend much time on them. But yes, the principles of ARDS ventilation remain the same over last more than 20 years. So these things must be remembered by each you being into that phase when you ask the basic. If you don't follow the basic principles, there only like the problem might arise. And if we stick to the basics, anyhow, we will surely ventilate the patient.
Yes. Thank you so much. It is it's a sea of knowledge. It is up to them to dive.
Yeah. Thank you, ma'am. Thank you so much.
Thank you so much.
Thank you, ma'am, for your valuable contribution, and thanks to both the speakers for such lucid presentation on topics which are of such importance to a postgraduate student. Thank you so much. So we'll move on to our next much awaited case presentation, which is of a female